Good afternoon, everyone. My name is Thomas Mekuria. I am a reproductive endocrinology and infertility subspecialist and the CEO of Center for Fertility and Reproductive Medicine. I'm very happy to be here today and present to you my article entitled Predictors of Successful In Vitro Fertilization Outcomes in a Resource-Limited Setting. Okay, so there are over 186 million couples in developing countries that are in need of fertility treatment. And as you know, fertility treatment is at its infancy in our country. Our center is only one of two centers that is capable of giving advanced reproductive solutions to our clients. But data is still lacking on the prevalence of infertility in Ethiopia, and it's estimated to be around 15 to 20%. And this figure is taken from a WHO. And one of the most important things when counseling women or couple in their success is to know their ovarian reserve. And ovarian reserve can be estimated using hormonal biomarkers like FSH, AMH, chromophil challenge tense, and inhibin. Nowadays, AMH and FSH are the most popular from the hormonal biomarkers, and from functional biomarkers, we can use antral follicle count or AFC. And genetic biomarkers are especially important in those which are very resistant or resistant cases of IVF or poor responders, and these include FSH, LH receptor tests for polymorphisms. These are new tests that are coming up and they are not routinely done. So from these different biomarkers, hormonal and functional markers, AMH and antral follicle count have been shown to be good predictors of ovarian response, especially in vitro fertilization. Yet, when we see the live birth and pregnancy outcomes, they have not been associated, both AMH and antral follicle count has not been associated, and their relationship is not straightforward. This is mainly because AMH and antral follicle count are mainly markers of the quantity rather than the quality of the eggs that a woman might have. When we talk of live births or pregnancy outcomes, age is the most important factor that has been shown consistently in multiple research, and age more than 35 to 37 has shown to have very low pregnancy outcomes or IVF outcomes, and this has been validated with many research. And age is becoming increasingly important in current society because of postponement of childbearing, and this is mainly because of modernization. And female fecundity rapidly declines after the age of 37, and there are numerous data that were used, and one of these is prospective cohort studies. This is a prospective cohort study of more than 3,000 women, and it has shown that if you see the graph, whenever the age is more than 35, the live birth rate and the pregnancy rate declines quite rapidly. It goes below 20% after the age of 37. Here also is the same observational study, and it has stratified patients based on their age. And as you can see on the right corner, women which are less than 30 years of age, despite having a very low ovarian reserve, have a better prognosis as compared to women who are older in that stratification. And you can see this, the horizontal axis is the cycle number, the number of IVF cycles that the women have, and in the vertical axis is the live births. And with one cycle, women who are less than 30 years of age, the pregnancy rate is around 17.6%. This is for poor responders. And if you see women who are more than 43, the success rate is very dismal, which is around 2.4%. So age is a very critical factor whenever we counsel on fertility. However, in our country, it's very hard to ascertain the age of women because they don't have birth certificate. Most of them they don't have birth certificate, and even if they do, they are very reluctant to disclose their exact age. So this poses a challenge in counseling regarding the success of IVF or other fertility treatments. And I also wanted to do this research because there are other biochemical tests, as we have discussed, like the AMH, day-3 FSH, and so on. And we wanted to see the association of these hormonal assays, as well as the functional assay, the unturned follicle count, with the outcome of IVF, because some of them are quite expensive, like AMH is expensive, and we wanted to see if we need to do expensive tests to counsel patients regarding their success. So the study is done at our center. It is a newly opened public IVF center. It has been 2 years now, and it has a diverse patient population coming from all over the country. Though the general objective of the research is to see the predictors of successful IVF outcomes, or to determine rather the predictors of successful IVF outcomes, and specifically we wanted to see the pregnancy rate and the factors that we thought would be important, like age, BMI, unturned follicle count, AMH, and day-3 FSH in relation to IVF outcomes. It's an analytic cross-sectional study design. It was done in a 1-year period between April 2019 to March 2020, and all patients that were enrolled during that study period were included in the study. Okay, and p-values less than 0.05 were considered statistically significant for the different bivariate and multivariate analysis that we used in our paper. So regarding the treatment protocols that we use for controlled ovarian stimulation, we used a long protocol in majority of cases. This is our staple protocol, and we also use short antagonist and minimal stimulation protocols in select patients. So we had an ethical approval from St. Paul's, and data was collected from charts. So during the study period, there were a total of 208 embryo transfers done, and 9 of them were frozen. So they were immediately excluded from the study, and we analyzed around 199 embryo transfers for the study. Long protocol accounted for 68.3% of the stimulations, antagonists for 10%, and minimal stimulation around 21%. And not surprisingly, the majority of women did not know their exact age. Around 65% of women did not know their exact age. And the reported median age is 32.5 years. Obesity was there in 10% of women, and 1.9% of them were morbidly obese. When we see the male parameter, the same analysis was normal in 75% of cases, and 1/4 had an abnormal same analysis, and 13% of the men required surgical intervention, testicular sperm extraction, to get the male gamete. The pregnancy rate is during the study period is 30.1%. Which is at the lower end, which is at the lower end. The self-cycle pregnancy rate worldwide is between 30 to 50%. This is because we had a critical malfunction in one of the batches of IVF. So during the first year, we used to do batches. Now we do continuous cycles. So during batching, what happens is there are 50 or more clients that are stimulated at the same time. And during one of the batches, there was a critical malfunction in the gas line. And because of that, the incubators were affected, and the pregnancy rate in that batch was very, very low because of that. And if we take out that batch from the analysis, the pregnancy rate is around 40.8%, which is comparable to anywhere, any self-cycle self-cycle pregnancy rates around the world. So that's why it was in the lower range. There was significant association observed between age, antral follicle count, and IVF outcomes. The chance of pregnancy doubled in women less than 35 years, which is also consistent with other research. So a significant association between age and a positive pregnancy outcome for both male and female partners. So the female partner is self-explanatory because, as you know, as the woman's age, the eggs, also the quality of the eggs decline. But the men is probably because younger women tend to marry younger men. That's the main explanation. Otherwise, it doesn't have a temporal association with success of pregnancy. Regarding the amount of FSH that is used per cycle, there's a significantly higher amount of FSH that is used for women above 35 years of age, which is again expected. Antral follicle count more than 5 was associated with 4 or more oocytes that were retrieved during an IVF cycle. Yet we did not find any association between BMI, FSH, and AMH. The reason being for FSH, it's probably not timed properly. As you know, early follicular FSH is the one that is used for ovarian reserve assessment. And we used to do the test outside because we didn't have it available in our center for the first year. So because of that, it might not have been timed properly. That's probably why there is a lack of association. Otherwise, in other research, it's pretty much a solid association between, there's a pretty much solid association between FSH and pregnancy outcome. AMH only, it's mainly a result of the sample. It's a sample size issue. We didn't do AMH for all patients. Only select patients had anti-mullerian hormone done, and that's probably why there is a lack of association. So AFC had a significant association with pregnancy outcome. As you can see here, the p-value is less than 0.05. And as expected, day 5 embryo transfers had better pregnancy outcomes as compared to day 3. And long protocols had also a similarly good outcome as compared to other protocols. This is mainly because of selection bias. As I told you before, long protocol is our staple protocol, and we tend to put all women, younger women with good prognosis on this protocol, and the others are usually reserved for poor responders. Okay, so here again I've elucidated that good responders, which means that women who have 4 or more oocytes retrieved had younger age as compared to the poor responders, and also the antral follicle count is much higher as compared to the poor responders, and this has a statistically significant association. In a subgroup analysis of the long protocols, both antral follicle count and AMH were found to be significant. This is because most of the AMH results had a long protocol used. Patients with AMH results had a long protocols as a way of control ovarian stimulation. And the age group for this subgroup was younger by 2 years. This again elucidating or showing the selection bias. Surprisingly, in this subgroup analysis, age did not have any relationship. This might be because most of them are of similar age group. As I told you, they are all young, so that might be the reason that there is no association in this subgroup. So when we see the strengths of the study, there's enough sample size for a baseline analysis, and it points out pitfalls for further improvements. But because it's a retrospective study, there are inherent biases that are that characterize the type of the study, and there is also, as I told you, in one of the batches there is a critical malfunction that resulted in a very low pregnancy rate during that batch, and that affected the overall result during that period. And this kind of thing happens in IVF setups just starting up, so it's not unheard of. So what happened is that we were very forthcoming about this, and the patients subsequently had other cycles in different batches, and they had most of them had successful pregnancies. The sample size was small for some variables. It was not powered, for example, for BMI, anti-Mullerian hormone, and so on. So further research is recommended, specifically targeting these variables. So in conclusion, the woman's age, reported age, even though we could not be sure about the age of the woman, but still the reported age and the antral follicle count had significant associations with ovarian response and the occurrence of pregnancy. And antral follicle count is a reliable and easy method for prediction of IVF outcomes. So it's not just reliable and easy, but it's also cost effective. So antral follicle count we can get from a transvaginal ultrasound, and we don't need to do more expensive tests to see for ovarian reserves. And we can use anti-Mullerian hormone as an adjunct in equivocal cases. So the recommendation, AFC, is can be used as a primary method for ovarian reserve assessments for fertility clients. And for future research, we recommend adequately powered follow-up prospective cohort studies. Thank you very much, and have a nice day.